Good morning to everyone. My name is Dr. John Anderson, and it's my distinguished pleasure this morning to introduce someone who has become a friend to me. Dr. Ellen G. Denton is a clinical psychologist and associate professor at the City University of New York College in Staten Island. She is a licensed psychologist and with a postgraduate training in pediatric psychology. She is trained in public health and clinical research methods. Dr. Denton has experience in providing psychological consultation services in Guyana since 2010. And she has a strong foundation to provide intensive training and mentoring that will contribute to building suicide prevention and clinical research capacity and resources in Guyana. And so I want to introduce my friend, Dr. Denton, to speak with you this morning. Dr. Denton.
Thank you, Dr. Anderson, for that lovely introduction. The title of my talk today is Suicide Risk Among Racial Ethnic Minorities in Low Middle Income Countries. And this is work I have attended and has been supported and funded by many persons and agencies, and so I would like to thank them all for using them. So as we can see here, the global burden of suicide is heavily populated within North America. And you're going to understand, hopefully throughout my talk, that I'm not really going to highlight the burden of suicide specifically in Guyana, but I have a specific research agenda that I would like to highlight. So, according to the World Health Organization in 2019, the world's highest suicide mortality is in Guyana, with a rate of 40, compared to other countries that are also indicated to be very high, like the United States. Suriname, to the right of Guyana, a country in the northeastern region of South America, also has very high suicide rates. So what do I want to point out? And that is, in this global community, I have a research agenda to not only include underrepresented minorities in scientific literature, but I'm interested in doing that with aim to build generalizable suicide models. It is not okay to come up with suicide prevention and intervention while excluding low and middle income countries. I will make a point throughout this presentation as to why. So it's not only that we have to include underrepresented minorities for obvious reasons, but as clinicians, as treatment interventionalists, as policymakers, we cannot build suicide prevention models unless we have the whole picture. And the whole picture does include low and middle income countries, which brings me to my aim of diversifying the suicide literature to be more inclusive of data from low and middle income countries. That is my research agenda. I will point that out to you here on the x-axis. We have age, and on the y-axis, we have death by suicide. And you can compare green to blue. And as you can see, blue is representing high-income countries and green low and middle-income countries. The preponderance of death by suicide is occurring in low and middle-income countries. In fact, the World Health Organization holds that 77% of world suicide is accounted for by low and middle-income countries. Yet, this is not represented in the suicide literature. In fact, Lopez and Cashman in their publication in 2015 indicated that most of the suicide research seems to be conducted in areas where there is no or very little suicide risk, that is, high-income countries. Why is the literature doused with findings from a high-income country? Well, that's obvious. There's great capacity to collect and produce data from high-income countries. That this conference is showing for that there have been many different investigators since the beginning, since I would say about the turn of the millennium, that have invested in asking these research questions about risk factors for suicide in low and middle income countries. And so that is my aim, partnering with those leaders, with those researchers and clinicians who are asking me such questions so that we can diversify the suicide literature so that it is not only represented by high income countries. So what is that LMIC? A low middle income country is a country that has a gross national income around 999, that's the bottom range, going upwards to over $3,000. Now, Guyana is no longer, according to the World Bank, considered a low middle income country, as Guyana income, gross national income, of 4,000 US dollars. So it's now considered a middle income or upward to middle income country. What is my program of research? It is really to examine, up until this point, the complex interplay of early adversity, social cultural factors, psychiatric racism, and personalization of suicide behaviors, and specifically among orphan youth. I'm very interested in the adolescents who almost are journeying throughout their early childhood and into their upper adolescent years, knowing that they're separated in some way from their biological parents and likely have increased exposure to trauma. Present to you some data that would be a little bit more clear. So what are the key clinical, my questions are, what are the key clinical risk targets for suicide among youth in low middle income countries, and what can we learn about suicide and suicide prevention by inclusively examining suicide risk in living samples? And let me bring back to my agenda here. I am interested in building generalizable suicide prevention and intervention models. My focus on high-risk samples and vulnerable populations directly points to that aim. While universal suicide, universally general population, universal suicide prevention models are definitely needed, we first have to reduce the risk or mitigate some of the risk, I believe, in vulnerable populations. And that's the beginning stage of how we will know we're building suicide generalized suicide prevention models. So this is all grounded in the theoretical framework. Thomas and May have the ideation to action theory. And what's interesting about the ideation to action theory, if I can make clear, is that in order to escalate to suicide risk, you start by experiencing pain and hopelessness. And what buffers or what prevents someone from advancing to a suicidal behavior is that they're connected to other people. And that pain then is theoretically going to be in some way reduced because they're connected to another person or person. And that's not only peer relations, but that's familiar relations. And then the question is, do they have the capability to harm themselves? Are they exposed to means of harming themselves? And then can they access harmful substances? So again, one will escalate from experiencing pain and hopelessness only if they're without buffers, connections within their familial or peer relationships. And then if they have access, then they will attempt suicide. And we'll see how this model is definitely applicable to vulnerable populations, such as orphan adolescents. So in Guyana, here in 2014, I worked with a team of social workers, and we went and visited, this is near the Linden area. I'm very happy to say that, because you all know where that is, right? This is near the Linden area. We went to our orphanage home. We did class and such with young persons, and I also collected clinical data, interviewing them using the VAS with the behavioral assessment schedule for children, which is commonly used in the States through psychology visa in the States to not only assess clinical factors, but also to assess the use adaptive factors. So what kind of resilience skills do the kids have? So just to name those scales, clinically we assess atypicality, which is looking at if the young person will enjoy, if they see things that other people cannot see, if they can hear things that other people cannot hear. We assess their social stress, we were asking them questions like, people act as if they don't hear me, other people ignore me, or I have a hard time making friends. That's going to be a very important clinical skill, social stress. Anxiety, depression, sense of inadequacy, attention problems, hyperactivity were all clinical skills that were assessed. We have adaptive skills that were assessed as well, and these are quantitative measures. And those adaptive scales include self-esteem, self-reliance, interpersonal relationships, and their relationships with parents. Those are the 4 adaptive scales. So we can see here on the x-axis those both clinical and adaptive skills. And then on the y-axis, we have the percentage of youth that have endorsed, the percentage of youth that have endorsed symptoms on each of these scales. And for the most part, you can see that these youth are reporting experiencing average symptoms, clinical symptoms, which is what we would expect from youth. If you ask a hyperactive ADHD child, are you fidgety? They will say no, right? That's the self-report. We typically rely on parents and teacher observations to understand ADHD symptoms. So the fact that most of the kids endorse average symptoms here is what we would have expected. What we do not expect, and what was out of range, we can just exit that box, please. Sorry about that. So what we would not expect is the clinical at risk range indicated for atypicality and social stress. So what does that mean? These youth endorse feeling in clinically significant ranges. These youth endorse seeing things that other people cannot see, hearing things that other people cannot hear, and also feeling ignored by their peers. Hello, we're sorry about that. We're in the presentation, but I am seeing you all in the chat. So I was presenting on just some preliminary findings from 2014 when we assessed the use. Oh, and if you can just write any comments if you're there, you can write any comments in the chat room about audio or sound. There's someone here who will pay attention to it. Thank you for that, and sorry for any technical comments. So orienting you back to 2014 data, when we assessed youth in the orphanage, their clinical and adaptive scale symptoms, we noted that youth are reporting clinically significant symptoms of atypicality and social stress, while all of the other psychological risk factors are falling within the average range for youth self-report, which is what we would expect. So when we move this, next slide, please. Next slide. So when we look at the association between those clinical risk factors and suicide reports in our sample, we see that in fact, interpersonal relations, just as the Klonsky and May's ideation to action theoretical framework we have predicted, we see that there is an association between feeling ignored, feeling as if they do not have friends to buffer their likely pain and hopelessness associated with being separated from their parents and living in the orphanage, that these young persons, that is significantly predicting not only their suicide ideation, but it is also significantly predicting their suicide attempt behavior. We also see that atypicality, hearing bad voices, having visions. I remember in particular one young person here in Guyana reported that their Grammy died, and so they have visions of their Grammy in the cloud telling them, don't harm yourself, but then they have another vision of their friends telling them, yes, you should go and jump off a high chair. Don't say that, right? But you know what I'm talking about, so the young persons are then battling. It seems like they're having these visual models or daydreams that are endorsing and then countering such endorsements. So that is a struggle. It might be a part of that theoretical model, the pain and hopelessness, the distress. It is for that young person to have to manage such symptoms and risk factors to suicide. Also, we're seeing that interpersonal relations, remember that it's an adaptive scale as measured by the BAC. So we're seeing that interpersonal relations can possibly buffer that risk if the youth are given coping skills to do so. The rest of this work is published in a descriptive paper with my colleague George and Christina Hogan, who are the organizers of this conference. So my next question, just from that descriptive data, it just leads to asking the real question: what are the modifiable risk factors that can be targets for intervention, or something that are psychosocial factors that we know will be important for these youth? So in a small sample of 50 youth, comparing those with attempted suicide versus those who not had suicide, we can see that those youth who are older, those who have endorsed symptoms, those who are female, and those who have endorsed experiences of trauma. We enumerated the amount of trauma experiences that you've had in the sample, and that was in particular because on average, you've experienced 8 or so traumatic experiences. How would we define traumatic experiences? These child welfare youth, it ranged from anywhere being exposed to sexual abuse and physical abuse, and it also, yes, we have a question. It also ranged from physical and sexual abuse, but it also ranged from the exposures to actually losing their parents at the hand of sexual or physical abuse. In this case, and what specifically, you can see that females have attempted suicide relatively more than males. So in this case, the youth who experienced sexual abuse, the young persons who experienced sexual abuse were removed from their homes and placed in the orphanage setting while the investigation was going on, which in some ways gives an indirect communication of blame on such young persons. The young girl, we had the youngest girl was 10 years old, and she, while they're investigating the case, she was removed from her home. So the blame and the responsibility that was directly communicated that she being the cause of sexual abuse is likely a trauma, of course, that is related to what we're seeing here in the data of suicide and behavior. I want to just point out the diversity of youth in the sample. You can see here that we have many Black, East Indian, Portuguese, Amerindian, multiracial. This is what the youth endorsed and classified the identifications to be. I'm going to point out somatization because we significantly saw more somatization among attempters relative to non-attempters. And this is important because indirect communication of experiencing pain and hopelessness seems to be a pattern in this data. I don't know how empowered, I don't know if the young person had the language, and in the second part of this presentation, I'll be asking for thoughts from the audience members, but we see that a lot of indirect communication from, in the form of health-seeking behaviors occurring while they're going to their adults in their lives and saying, I have aches and pains, I have body weight, I have persistent headaches, and that seems to be indicative of something more going on. So it's the physical manifestation. There's a great paper, Hageman in Social Science and Medicine, the data coming out of Haiti, that also notes that somatization was the way that people communicated their suicide risk in low middle income countries. And as expected, things like depression, severity, anxiety, psychosis, and repetitive thoughts and behaviors, the youth endorse that they feel the need to check things, they don't feel safe. That is occurring over and over again in suicide attempters relative to non-attempters. In this study, we used those clinical risk factors to predict suicide attempt behavior. That was one question. We also wanted to predict how many attempts of behavior, because in that sample of 50 youth, we had youth who attempted suicide up to 5 times in their short lives. There was no youth, remember, in our sample over the age of 21. So some of them had, the majority of them had 1 suicide attempt, but we also had youth that had 2, 3, and up to 5 suicide attempts. And we all know in the literature, the suicide literature, we know that for every 20 attempts, we in general, in the general population, we have a suicide completion. So if one young person before the age of 21 has over 5 attempts in their lifetime, it is a strong predictor. Goldstone et al. Published a very important paper indicating that more attempts in your childhood is predictive of death by suicide in the future. So we wanted to predict how these psychological symptoms predicted the number of suicide attempts. We did that using a Poisson regression analysis. And what we see here is that the number of traumatic events that the young person experienced and those atypical or psychotic symptoms, seeing things that other people don't see and hearing things that other people don't hear, were predictive of increasing number of attempts. Specifically, for every one increased traumatic suicide attempt, there was an increase of 1.13 of a traumatic event in their life. And I'll say that again. For every one increase in the suicide attempt that the young person had, there's a 1.3 likely increase of having experienced a traumatic event. Likely a 1.27 increase of psychotic symptoms for every one increased suicide attempt. The rest of this data, there's some very interesting things in this paper. This data is published in Suicide and Life-Threatening Behavior. So what I just want to jump to the lessons learned from this data, and I'm interested to hear thoughts from our audience member and our introducer. I really am, because we learned some things from this data moving forward that is in some ways inexplicable by the findings in high-income countries. And I really think that we have to go to this one to understand these findings. So in particular, what is one thing that we found? In the data collected in 2014, 2016, 2017, and 2018. The 2017 data is indicated in green here because it includes orphans from South Africa, which it was similar to Guyana. It was a previous British colony. Similar to Guyana, it was also a previous low middle income country. Similar to Guyana, it is no longer a low middle income. So we have the orphanages from both Guyana and South Africa here. And over these years, in all of these samples, we have consistently found that there are youth are reporting more attempt behavior relative to ideation. So they're saying, I have attempted suicide, and they're not endorsing current thoughts about suicide. That is not what we would have expected. We would have expected it because typically young persons have ideation more than attempt. We're not seeing that among vulnerable youth in low middle income countries. There's data from Supermith in Estonia that shows that. There's data from Haiti showing that. Then in low middle income countries, persons are endorsing suicide attempts in some samples more than ideation. Ideation is variable, and we don't really understand why. One plausible reason here I have is that it's a complicated thought. You know, to endorse suicide ideation means that you're challenging thoughts, you're thinking about it, you're probably going back and forth. It might take a cognitive maturity or sophistication to communicate that to another person. And so maybe that's why they're not endorsing that. And there's some data explaining that theory. It can also be they have no one to say this to. So they might not trust someone enough to say, yes, I'm currently thinking about suicide. PsyD et al. Has published a wide range of literature showing that having communication with adults is quite important for young persons who have adverse experiences. And so if they're unable to communicate to a trusted adult such complex thoughts, then they're just going to hold it in and withdraw. That might be a reason why they're not endorsing it, but they are endorsing the behavior. Another reason is that they might be telling us what we want to hear, social desirability. And this is happening in low middle income countries. Horowitz et al. Has looked at having equipped persons to really ask these questions can allow people to be vulnerable, so they will tell you. But without that, they'll just tell you what you want to hear, which is, no, I'm not having thoughts about suicide. Oh, but I have attempted suicide. So those are my plausible explanations. I'm very interested to hear why, since we're here in Guyana, why we think that these youth are endorsing more attempts relative to ideation. We've also learned to throw them a birthday party every time that I have gone to the orphanage. So it's been a privilege to celebrate the life of these young persons, and we throw them a birthday party. There are limitations to my research. Of course, the tools were not validated or normed for limit populations. So I use things like the Beck Depression Inventory, which Beck, God rest his soul, he recently passed away. He's been a big influence in all psychological research with the Beck scales that recently passed away. But Beck notes in his scales using the Beck Depression Inventory that these scales were normed on white samples. And while they're heterogeneous as far as ability, from deaf and visually impaired, there's heterogeneity there. There's not heterogeneity on the ethnic racial diversity. Also, I've used small sample size because I focus on orphan youth. Also, this has been exploratory research and there's criterion validity, but I did test the criterion validity by looking at the scales such as the CESD, which is the Center for Epidemiological Scale, the children's version, the depression scale, the children's version. And we also use the Beck, as I told you. We use the Child Depression Inventory, also published in Beck, and the DSM-5, which were made from the clinical field trials for use all around the globe, and the hopelessness scale for children. And we wanted to compare these scales functioning and see if it discriminated, which gives criterion validity, right? Will these scales discriminate between those who are suicide attempters and non-suicide attempters? And will we find a significant difference? And indeed, we did find that the CESD, on the CESD, the Beck Depression, the Child Depression Inventory, and the DSM-5, we did see that there were significantly higher depressive symptoms among those who had suicide attempts relative to those who do not have suicide attempts. And so we know that these scales, these scales are doing what they're supposed to do if they are not only the direction is in this right direction with high depression severity among the suicide attempters, but then also it's a clinically significant finding. So what else did we learn? I'm going to bring you back to Tomsky and May's theoretical framework that one, these kids are experiencing pain and hopelessness. They're experiencing traumatic events, separation from parents, chronic symptoms of anxiety, of atypicality. That is pain and hopelessness, and it's manifesting in psychopathology. Also, to right in line and consistent with theoretical framework, that these youth are experiencing interpersonal relationship issues and social stresses such that adult-led engagements are missing from their lives, and that might be related to the escalation of their suicide risk going to attempts and behaviors. So just to summarize in some ways, I wanted to go over these highlights and these findings that we have in both our South African and Guyanese sample. As I said, there are some similarities there. And what we saw again is that there's more endorsement in both South African and Guyanese orphans of suicide behavior attempts relative to suicide ideation. That's one. We're also seeing that psychopathology symptoms such as ADHD, depression, social stress, anxiety, somatization exist in these samples of youth and are predictors to their suicide risk. Specifically, what did we find when we tested the association between psychopathology and suicide ideation attempts and overall suicide risk? Well, we see that atypicality, again, is a significant predictor of suicide ideation. We see somatization is a significant predictor of suicide ideation. And lo and behold, in line with the ideation to action theoretical framework, social stress is a significant predictor of suicide attempt behavior. So we know that these youth are experiencing social stress. Just to highlight this finding, it was moderated, the somatization finding was moderated by gender or sex. And so on the x-axis here, we have
somatization. On the y-axis, we have odds of suicide attempt behavior. And if you see here, males in particular who are attempting suicide are somatizing. They're the ones who are coming to others around them and saying they have body aches and pains. That's the way they're communicating their risk for suicide. While on the other hand, females are not doing that. Females are withdrawing and internalizing. And that is a very interesting finding to see this indirect communication, because usually women will be the one to more likely seek help for any of their psychopathology symptoms. The literature is very clear on that. But what we're seeing here is that these girls, these orphan girls, are withdrawing and holding in, and that is associated with their suicide attempt behavior. So directors, the implication is very clear. When the young girls are withdrawing and staying to themselves and isolating, there's risk there. While when the young men are seeking help for physical symptoms and not actually saying that they're having mental or emotional problems, that there's risk for suicide attempt behavior there. So what are the next steps in this research? And I'm going to pause here because I do want to have that discussion from audience members as well as the panel member. What are the next steps here? I think that I have made the case that one, limit the risk for escalating suicide to attempt behavior aligns with the theoretical models. And we're seeing that kids in LMICs and in high-income countries alike are experiencing pain and hopelessness. That pain and hopelessness is not being buffered by social connections. And with access to lethal means, they will attempt suicide. And the data is clearly supporting that. I've also think that I've made the case through these data that that these risk factors of psychopathology, such as somatization and anxiety and trauma, are definitely evident here. Ways to address it, we would have to be creative about it, yeah? Especially for youth who might not have regular visits with a therapist or are going to see their doctor often. We need to talk about how we can get care to these young persons. So then the question is, what are the interventions that we can propose? Now that we've outlined these risk factors, I'm convinced it aligns with the theoretical model. Should we focus on the individual level, on improving or reducing these symptoms, these psychopathology symptoms, or should we focus on the systems level of building coping resilience, so giving psychoeducation and providing a supportive normative environment for these youth? Also, it could be that attempt, the endorsement of more attempts relative to ideation. We might just need to help foster more adult-child communication, and how we do that and what that looks like is something that we should we can explore. I'll end on this point. I am well aware that these models have to include task shifting, because the burden often falls very heavily on one person or one expert, right? And that is not feasible when we talk about an increased risk, and when I talk about, I'll bring you back to my first slide, suicidal, generalizable suicide prevention models. It is not feasible for the burden to fall on one person. So we have to talk about task shifting interventions. Who can we collaborate with? Who might be maybe a lay person, or who might be a supportive professional to aid in disseminating these suicide prevention models to those who are very in need for it. So I thank you for your time, and I do ask for thoughts, feedback, and if you don't have any of this back, I will ask a direct question. Thank you again.
Thank you, Dr. Denton. Thank you, Dr. Denton. Certainly, I think that was an excellent presentation. Yes, certainly that's an excellent presentation. And a lot came out there. And I do want to comment on two aspects of the presentation. But I would first give the member of the audience an opportunity to take the first shot at commenting, so that I don't take away that opportunity from her. Go ahead, ma'am.
The aspect of why we care from our I see more attacks coming out about adolescents rather than
Ideation.
ideation. One of the things that from my work in doing suicide work is that we would have seen a person act on impulses. They tend to get out. I want to get out. My objective is to get out. I have a problem, so I'm going to eliminate myself. And that, even if it means killing myself or harming myself, with the objective of getting out. Right? Impulses is one. The other thing is that the engagement with adults, they don't want it because they're oftentimes judged or they're oftentimes put down. Like, what kind of problem you will get that you want to kill yourself? So rather than addressing the adults and say to them, this is what I'm feeling, this is what is going on with me, I keep it to myself and I'll deal with me how I know best.
Yep.
With the next step, while we want to engage the lay person, I think it has to start with policy level. We have to have policies that include our youth, that let them feel a part of what is happening. So, and even in the awkward situations, they're oftentimes structured. Some of these youths are coming from home where there were no structure, they were existing. And now you're putting me in an institution where I have to follow rules. And prepare me to follow rules. Because I wasn't following rules all the time. There were situations where they were running me home. And now you're telling me I have to follow instructions. And some of these youths are coming from situations where they were running home from 5-year-old and 6-year-old. And I'm 30, you're putting me in an institution where you're telling me I have to answer a house mother, a house father, and I was the person making the rules and saying who could not. So I am now in a confusion because I'm not used to this. Now you're telling me I have to do this. And you never prepared me for that. So we have to look at how are we want these youths to be better, but we don't consider their world. We just put systems in place and think, okay, this is the best thing. This is what they need. And I'm consulting them, and so I know force what I want to do. So the bad behavior can change, and I'm going to bounce from home to home to home to home because nobody can handle it, not understanding where I'm coming from. And then, look, my friend would have attempted to get through, so I'm going to do the same thing. So it's escape. It's oftentimes an escape out of whatever is going on. So that's my thing.
Thank you for that. Can I just ask another question? Are there any questions in the chat? So can I just follow up by that? Thank you for that. Boymeister et al. Has published quite a bit about escapism. That was definitely nice of you to explain that quite clearly. When you say that adult-led engagement, can you just explain that a little bit more? Must start on the policy level. That is counterintuitive to me. How can policy make an individual more relational?
There's a lot with the policies that we have now. There's a lot of bureaucracy. And sometimes we think one kind of exists without the other. And there are certain steps that we need to follow. If these steps are not followed, we don't think it can happen. The other thing is that while we want policy change in terms of letting these youths not only be engaged in the process of getting them well, but also we need more persons involved. So rather than just bringing them out of the environment and placing them in a home and then they see a social worker or therapist every 6 months, we want them to prepare them to go into that institution while they're there to assist them in that institution can bring, rather than just us telling them what they need to do. So it's not us just handing them something, but we take it from them so that we can better prepare them for their world.
Yep.
Thank you.
I can tell that you're speaking from a rich wealth of experience. I hear that coming over. And she's very passionate about what she does. We like passion in this room. But I want to comment, and feel free to raise any new points that you want to share. So as it relates to suicidal ideation and suicide attempts, what I think is that the lack of societal acceptance or lack of societal engagement, meaningful engagement, as it relates to suicide and all that it entails, prevents young people from feeling as if there is a framework within which they can express that thought process. And so the better thing to do is to deny the existence of that thought process and bury it somewhere at the back of their consciousness. But it's obvious that that action had to come from a place. So there is that place, but to accept that there is that place in me means that I will be putting myself at risk for societal rejection. So when you mentioned education and information, I thought that was very important, because if the societal understanding of appreciation does not change, then there is no avenue for those young people to express how they really feel. And so in our local context, just what the contributor, Ms. Solomon, said, quite wisely so, when a child goes, or a young person goes to a parent or a parent figure and says, I have this problem and I'm feeling as if I want to commit suicide, the exact expression that she pointed out to us is what they hear. What could possibly be wrong with you that you want to commit suicide? And that conversation oftentimes does not happen in a very cordial manner. It happens with a very hostile tone, so that that child knows that that conversation needs to die right there. Don't bring it up again. That's it. So that from that point, the burying into the subconscious begins. And then, so if you ask, so by the time they get to you, the therapist or whomever, and you ask the question, do you have any suicidal ideation? Oh no, I don't think those thoughts. Certainly not. Because they had that experience before. And they have already been confronted with rejection of that thought process. Engagement and exploration would have been the better approach. So why do you feel this way? What's happening? That doesn't exist in our society. And I'm saying that across the board and in a very generalized manner. We do have persons who are trained and understand this differently. But in society in general, you will find that rejection of the very concept that you're thinking this way. So therein begins the burying, the hiding, the suppression. So when you interact with a young person who would have attempted suicide and you ask if there was a preceding ideation, a person says, no, I just got up this morning and I felt like I wanted to do this. So how then do we explore with the client or with the person the root of their problem? If they themselves have been forced to bury that issue way back in their subconscious. So that's where, so I think education is important. Society needs to be informed. We need to have a lot more workshops like these. We need to have a consistent community program to teach, particularly the older folks who have not been socialized to embrace their emotions and to engage. That's not part of the general culture. So that's the group that you would hope would be able to engage the younger people. And that's where you have to begin the education and that work has to be consistently done in the community, I think.
Thank you so much. What I'm hearing said, and for the sake of time, I want to make sure, are there any questions in the chat? We'll be ending and transitioning to another session now, but what I've heard from the audience has been quite helpful in interpreting these data. Specifically, Dr. Anderson is saying, what I would have thought that we need education to help those who have come from a British slave-based post-traumatic slave. Dr. Joyce Leary points this out in her research. Post-traumatic slave syndrome, with a hostile, dismissive manner, is cultural, and that comes from a historical context for those nations that unfortunately were under the difficulties of slavery, to put that lightly, the oppression. And so what he's explaining is that education, that psychoeducation on how to change your tone, how to engage young persons needs to be done on the individual level. But what so nicely Ms. Solomon added to that is that it might not, the individual level, yes, that's a low-hanging fruit, but policy that allows these young persons two things. One, they get arts and crafts and skills, and I must then acknowledge Ms. Anne Regan, Child Protective Agency. I know the Sophia Home has multiple activity bases for those youth in care. And what Ms. Solomon is saying, and I suppose what Ms. Anne Regan knows through that leadership, is that when the youth have these skills and these activities and crafts and such, it will allow them to open up more through that activity-based engagement to adults, one. And two, Ms. Solomon is saying, and we want to take it as wide as Dr. Anderson. Two, Ms. Solomon is saying that adults, that the young persons need to be prepared when they're being placed in the institution. So having multiple persons saying that you're going into an environment with structure. This is how you use the social worker. This is how you talk with your peers. This is how you talk with these other adults that will prepare them to utilize that which is available to them. So one, that the burden is not on one person, but two, so that the youth are ready and can maximize and capitalize that experience and hence reduce their suicide risk. Thank you. Thank you. Listening and engaging is certainly a privilege.